Well, very briefly, if we look back historically, of course, up until about the 1960s, healthcare could really contribute relatively little to improvements in population health. We didn't have the modern medications, we didn't know how to use them, but that changed. And in the 1960s and the 1970s, we saw for the first time the major killers in late middle age, hypertension, chronic airways disease, and so on, being possible to be treated. So that revolutionized the practice of healthcare, and we saw in Western industrialized countries a progressive decline in mortality from those conditions. Now that has continued, but we see in some of the wealthier Western European countries, for example, the big gains took place in the 1980s, then later in Southern Europe in the 1990s, in Central and Eastern Europe in the 2000s. The challenge, of course, we have now is that we have had these great successes, and the challenge we face is to improve the quality of life, as we now see that we've been able to manage most of these conditions.
How will this balance be affected by the future changes that are now coming in clinical medicine? The ability to use genetic mapping to generate individualized pharmaceutical treatment plans, for example.
I think the challenge of individualized medicine is really one for the pharmaceutical industry primarily, because they base their business model on one in which they would find a condition that affected a large number of people and where treatment was begun in middle age and they continued to take that treatment for the rest of their life. Now, they've run out of those conditions with the exception of dementia, but all of the other conditions now have perfectly good treatments. Again, heart failure, chronic airways disease, the common mental disorders, and so on. As they look for new uses for drugs, they're focusing on much rarer diseases, and particularly with the new genomics, we think primarily of cancer. And we take a label like breast cancer, but of course breast cancer is a spectrum of conditions, including some of which are estrogen receptor positive, some are estrogen receptor negative, and so on and so forth. And with the much more specific drugs that are being used, the number of patients that can benefit from them is much, much smaller. But of course the costs of drug discovery and development are the same. So the cost per unit of medication becomes much greater. That is a challenge for the pharmaceutical industry, but it's also a challenge for health systems as they struggle with how to pay for these very expensive drugs that will benefit only a very few people.
So to pull this together, it's improving quality and access on the health system side, where the major contribution remains to be made to health gain, more than the various initiatives on the public health population science side.
It's very difficult to divide them up because clearly there are countries, many countries, that still have a great deal to do with, in terms of achieving what can be done with simple public health measures, smoking, for example. Obviously, public health still has a lot to do. We look here in the Nordic countries at the success that you've had with alcohol, but of course some of that has gone backwards. In Finland, for example, with the dismantling of the regulatory system. So clearly much more work to be done there. Public health still has a very important role to play. But in healthcare, if we look at a condition that we've been able to treat really since the late 1950s, hypertension, everywhere we look across Europe, we see 20–30% or more of people who have been diagnosed with hypertension who do not have their disease controlled. We still have far too much unnecessary cerebrovascular disease, which places a huge cost on the healthcare system. That clearly could be addressed, but that is a matter of getting better blood pressure control and ensuring that those people who have high blood pressure are diagnosed and treated. That's where the really big gain will come.
So the big gain then comes from using what we already know and applying it more effectively. Quality, access, blood pressure control for hypertension.
That's right. I think if we could ensure that everyone got the best available treatment given what we already know, we would be a long way towards our target of health for everyone.
One final question. How does austerity, particularly if austerity turns out to be a decade of austerity, how does that alter the way in which this process will unfold?
I think we have to ask ourselves whether austerity is actually an economic issue or a political issue. And in fact, I've recently heard a number of politicians raising this as a question. We could look at the situation in Greece and say that in terms of the total European Union budget, it is actually fairly trivial. It could be solved if the larger European countries decided to get together.
So you're basically going to dodge the question, say austerity is a political choice, it's not an economic necessity, and therefore it's not necessarily relevant to this discussion.
No, I'm not saying that it's not relevant, but I would primarily say that it is a political choice. I'm saying that if we look in the United Kingdom, for example, which has adopted austerity policies, it is not achieving growth. It has now got a higher debt level than when we started. Economic growth has been completely shut off, and in a recent paper we demonstrated very clearly the coincidence between the adoption of the austerity policies and the shutting off of the economic recovery. So there are governments that choose for their own ideological reasons to pursue a policy of austerity. That said, of course it has implications for health, and we of course have studied this historically, looking at the Great Depression, looking at economic crises in a number of countries. Quite simply, what we find is that in recessions we see rises in suicides and reductions in deaths from road traffic injuries, at least in those countries where there is room for them to fall further, because of course in some countries they're already quite low. Your answer as to what you think will work will depend on what you believe about economic theory and your political views.
So economic theory is just a belief system. There is not an actual finite amount of resources that has to be reallocated.
Well, of course, there is always scarcity of resources, but the question is whether you use those resources and invest for growth, or whether you cut back on what you have because you want to get the debt down in the short term. And that is a debate which was thought to have been settled in the 1940s, but of course the stagflation, Japan and so on in the 1980s challenged the Keynesian interpretation, and I think it's fair to say that the jury is out on that.